I hope you can hear. I hope you can hear me. My name is Marc Bonten. I'm an infectious disease epidemiologist in Utrecht in the Netherlands, and it's my pleasure today to introduce to you Ganna Rozhnova, who will give today's webinar, Making the Most Out of Infectious Disease Modeling in Fighting COVID-19. Ganna is a mathematical modeler working in our group at UMC Utrecht, and before the COVID pandemic, her work mainly addressed HIV and also other sexually transmitted diseases. But of course, during the COVID pandemic, all soldiers were called to arms to inform us about what to do to control the pandemic. And Ganna is working in a relatively small but very specialized group of researchers, mathematical modelers, and we had regular discussions about the questions at hand at different stages of the pandemic, for which we definitely see, let's say, needed at least information about possible scenarios. And that's, I think, typical the field where mathematical modeling can inform policymakers on policies during changing situations. Ganna has worked tremendously hard during this period, and she has produced and published some very, very good papers, I think, but I'm not completely unbiased, of course, and I'm very pleased that she's willing to share that information with us today. So without taking more time from Ganna, I'll ask her to start, and at the end of the presentation, there will be room for questions to be answered. Ganna, please go ahead.
Yeah, good afternoon, everyone. Thank you very much, Marc, for the introduction. I can say that in much this work was influenced by the questions that you were also transmitting to us modelers during the pandemic. So just for a start, so I have, I think, maybe a different background from the people who may join this webinar. So I'm a physicist by training, and I build infectious disease models to understand the transmission dynamics and the impact of interventions on transmission. And this webinar will be about the work that was done during the pandemic. So I don't have any conflicts of interest in connection with this webinar. So what will I like to tell you today? So I think that in short, I would like to show how we can build the reasonable transmission models. And by reasonable, I mean that these are the models that are rooted in some knowledge about the pathogen. So they include the minimum biology that we need to understand their transmission, but these are also the models that are fitted to the data, that reproduce the data, and that report the uncertainty correctly around the data. And I want to tell you how these models can provide insight and how they can inform policy. And at the end, I will discuss some of the advantages and disadvantages of our approach. And for this talk, I chose 3 case studies that I will present that were done during different periods of the pandemic. And I would like to acknowledge all the people with whom I have worked in the past 3 years on these topics, and they mainly split between a few groups. So this is a group from Lisbon, a group from Utrecht, and the group from New York and Tilburg University. So I boxed some of these people in some of the people in red, as you can see. And I did that because these people, so Marc Bonten from Utrecht and Manuel Gomes, they have been the people who have communicated a lot of the questions that we addressed in the research. So they were closer towards policymakers. Marc is was a member of the outbreak management team in the Netherlands, and Manuel Gomes is a member of the vaccination committee in Portugal, and he was also one of the main advisors on the pandemic in Portugal. And Ottilia is, she's in the bottom role, so she's my current collaborator, associate professor in the Department of Econometrics in the Tilburg University, and we have some ongoing work that I will tell you about. And of course, this work also received quite a lot of attention in different countries and in different languages, but I'll not stop at this. So first of all, well, why do we need models? The models are used as a tool to inform policymakers, and we use models for at least a few reasons. So when a new pathogen emerges, we need to understand the epidemiology of this pathogen, so the basic characteristics about the pathogen, how fast it's transmitted, and so on. And that's what model can do. The model can provide insight into the mechanisms that drive the pandemic. For example, the age-dependent transmission, who transmits infection to whom, and so on. And the models can help to estimate the impact of interventions that have already been implemented. Usually when a new pathogen arises, so everything develops very fast and quickly some measures will be taken, like lockdowns, for example. So we can do that, but we can also estimate the potential impact of future interventions. We can use the models to project the trajectory or the dynamics of this infectious disease forward in time. And frequently we do this using a scenario model. And so we formulate different scenarios that we want to consider, and we see what the possibilities are. Finally, we can also look retrospectively and say what would have been impact, for example, of different interventions if we would have implemented them. For example, if we opened school at some point, we can ask now retrospectively what would have been impact if we wouldn't have opened schools. Or other similar questions, for example, the vaccination campaigns would progress in a different way. And there are many different types of models exist, and there is in this figure that you can see there is a whole spectrum. So there are like the simplest models, the homogeneously mixing models, and they are just shown, the people are shown as a sort of circles of different colors, and different colors represent the different disease status of individuals, like susceptible, or those people who are infected and actively infecting people, or recovered. And then if you introduce one additional layer, such as social structure, for example, when we start categorize people according to their age or risk category, then we have more complex models, which are called heterogeneous models. Then if we include even more information, for example, about the contact structure, so about how the pathogen transmitted along the contacts, we can have contact network models. Then there are different variations of these models. For example, if you consider a well-mixed homogeneous population like this first one, but in different regions, and you assume that there is some type of movement or of individuals between regions, then you get the multi-scale type of models or meta-population models. And the last ones are the agent-based models. So they are really complex, they're very detailed, they include a lot of information about all the individuals, about all the actions they do, and they consider the transmission of the disease in this detailed type of world. So today I will tell you only about the two types of models. So these are models with social structure and the meta-population models. Okay, so the three case studies that I'll present are about, they refer to different periods of the pandemic in two countries, in the Netherlands and Portugal. So case study one, it will be about the school-based measures in the Netherlands. Then I will address the vaccination against the SARS-CoV-2 in Portugal. And the last one will be the age-specific transmission dynamics, again, in the Netherlands in the first 2 years of the pandemic. And everything that we are doing is open source. So if you are interested, or if someone is interested, so we have all the codes that are publicly available that can be downloaded and checked about how we do things. And also this work, it's already published for the two first case studies. It was published last year. And the third case study, it's a work in progress, but it will soon be also, hopefully soon will be finished, and we will also deposit it on medRxiv. So let's start. So for the first case study, one of the really important questions was in the beginning. So what is the role of school children and school-based contacts in the transmission of SARS-CoV-2. And that was not really clear. So we can make, of course, different assumptions that it behaves in a similar way as influenza, for example, the SARS-CoV-2, but it was not clear. And this is really important because if children are very important in transmission of SARS-CoV-2, then you also probably need to use measures to stop the transmission that you implement in schools. But on the other hand, we have a high priority to keep schools open, of course, because we want that the children continue to receive education in a normal way. But it's not clear, on the other hand, how we can keep the pandemic under control. So the questions that were transmitted to us by Marc at in 2021, that was end of 2021, is so what are the effects of these school-based measures, including the school closure on transmission during the course of the pandemic? And if we want to keep schools open, how much we need to reduce contacts in the rest of the society, so outside schools. And you can think in this in an abstract way. So you split all the world into schools and not schools, and you can think of different interventions outside of schools, for example, remote work or, well, closing restaurants and so on. So different types of measures. And in the Netherlands, so this is the timeline of the Dutch pandemic. On the y-axis, you have the average number of hospital admissions over a week, and on the x-axis, you have the timeline. And you see that this is the period our study concerns, this red box, where we had the first very big wave in the Netherlands in spring 2020, like many other countries, including Germany, I think. Then in summer, there were very few hospitalizations. And at the end of summer, also a lot of measures were relaxed. In particular, the schools were completely open. So at the end of August, after the school holidays, the schools are open entirely. And you see that at the same time over here, so this big wave started in the Netherlands that almost coincided with this opening. And then there was a second semi-lockdown was introduced. And at this point we were asked, so how much actually the schools contribute to transmission? Do we need to think of the measures that would target schools to help achieve the control of the pandemic? And we use transmission models. Well, I think we won't go in any of the technical details, but basically what you do, you stratify all the population into different groups according to the disease status and age. So these different groups are shown as boxes of different colors. So we think of susceptible, so these naive individuals who never were infected. Then the susceptible individuals can get infected if they come in contact with an infected person. And then we have they become latently infected. So they're infected, but not yet infectious. Then after some time, they become infectious and they start transmitting the virus to other individuals. So these are red series of boxes. And then after the infection, you either recover without hospitalization, or we consider that you are hospitalized with some probability. So this is the essence of this model, and all the rest is kind of complication. So for example, there was a lot of discussion going on about whether the susceptibility to infection with SARS-CoV-2 is age dependent, and we also implemented this in our model. So we stratify the model into several groups, risk groups. So according to age, so we have 10 age groups, 0 to 4-year-old, 5 to 9-year-old, 10 to 19-year-old, and so on. And everyone who is older than 80 is also grouped into one age category. Then we have 8 hospitalization groups, because hospitalization probability in children is quite low. We know that the hospitalization burden in children is, in general, is not very high. as compared to all the individuals. So we have one group of 0 to 19-year-old, and then we also have 3 broad susceptibility classes. So roughly individuals until 20 years of age, 20 to 60, and everyone who is above 60. And we formally use methods such as a Bayesian inference to feed our model to data, and we use 2 data sources. This is a hospital admissions in the Netherlands in different age categories, and also age-stratified serological data after the first pandemic wave. So we also use information about the age mixing patterns in the population. If you think of all the population, how disease is transmitted depends on how many contacts people have between each other. And this number of contacts is strongly age dependent, and information is collected in surveys about the number of contacts people have. And here is an example. So this information was collected even before the pandemic. And you see on, for example, in this left top graph, you see the average number of contacts on the x-axis, average number of contacts one individual in a given age group has. For example, let's fix one which is 10 to 20-year-old with other individuals in other age groups. So if you look how many contacts one 10 to 20-year-old has with other 10 to 20-year-old, you see that this is shown in color, and it's very red. So it's about 9 contacts per day on average. And there is some sort of pattern that we see in the number of contacts. So it's kind of diagonal. So many people have contacts, or the largest number of contacts with individuals of similar age, which is why we get very pronounced darker color on the diagonal. And that's normal, because normally when people make partnerships, they have, well, or very frequently, they have similar age, and also the children, they mix very well, or they have a lot of contacts with their peers at schools. And actually the largest number of contacts they have is at schools. And so we have this information in all locations in general population before the pandemic, but we also have this information in schools before the pandemic only, which is shown in this bottom graph. And then also the surveys were obtained to obtain the contact data after the measures were introduced during the first lockdown. So as you see, the whole structure changed, and it's not as any more pronounced on the dark diagonal, because in particular the schools were closed, but also a lot of other things happened. So like most of people started to work remotely. And overall, there was a 71% reduction in the number of contacts that a person on average has in the Netherlands with other people. So the color here corresponds to maximum color is 1.5 contacts. So this was the strangest lockdown that we had during the start of the pandemic, the first lockdown. So we use this information. And then we fit the data, the model to the data. And so the data is shown as red dots. These are hospital admissions per day in different age categories. And we, from top left until bottom right, we go from the youngest in age category, so 0 to 20-year-old, 20 to 30, until the oldest ones who are 80 plus. And you see, so the x-axis shows the number of days after the first official case in the Netherlands. And so this was the first wave. And in the oldest individuals, of course, the largest number of hospitalizations were observed. So you can see kind of a quite nice veil, the shape. And in the youngest individuals, the pattern is not so pronounced because there are fewer hospitalizations. So it's more like a random process, let's say. So we also fit the model to the seroprevalence data, which was collected after the first wave. And here you can see, so the red is actually the model, and the black dot with whiskers is actual data that was collected in different age categories. So the seroprevalence was very low. So the number of, or the percentage of people who have been infected was very low. There is also no immunity waning at that point. And on average, they were between, 1 and maybe 3% of individuals have experienced COVID-19 during the first wave. The seroprevalence was a bit lower also in children. So what do we learn from this fit? So we learned at least 2 lessons. So the first lesson is that susceptibility depends on age. So as I told you that we split the population in 3 broad age groups. And as you can see that these are the distributions of the susceptibility obtained from the model fit. And we observe that, or we find out that susceptibility of the 0 to 20-year-old relative to the 60-plus-year-old is 23%. But the susceptibility of 20 to 60-year-old is also lower. They are 60%. The susceptibility is 60% relative to 60-plus-year-old. And this, of course, affects how the virus is transmitted in the population, because while the children have quite a large number of contacts because of the interaction with peers in schools, the susceptibility is quite low to the virus. Then the second lesson that we learned was that the probability of hospitalization increases exponentially with age. So in this graph, I'm showing you on the x-axis the age from youngest to oldest, and on the y-axis the probability of hospitalization. And this graph is shown on the logarithmic scale, and this looks like almost a straight line, which means that on the normal scale, this probability of hospitalization will be increasing exponentially with age. So this is, of course, very important because let's say the probability of hospitalization, it basically informs how we should be developing our vaccination strategies. Okay, so let's move further. So we can now, when we have this model that's fit, we can ask or try to answer our policy questions. And the main quantity, let's say, that we calculate when we try to answer policy questions is the effective reproduction number. Effective reproduction number, I think many people may have learned during the pandemic the meaning of it and the definition, and it means the average number of people one infected person would infect in the population with measures. So if you on average infect more than one person, then you get basically an outbreak, you get an exponential growth. So the number of cases would increase, and if the reproduction number is smaller than 1, then the number of cases will decay. So basically the cases can't reproduce itself, and so it has to die out. So the goal of any intervention is to reduce this effective reproduction number to below 1. So the question which we will ask is how much. So I told you that the schools opened after the summer break in August. And the questions that we were asked, how much did the other contacts in the society had to be reduced so that we could keep schools open, but still prevent this large second outbreak? And the second question was, well, what would have happened if we actually didn't open schools after the summer holidays, if you would have just only remote education, but not in-person physical education? And well, here are the results. So we have the reproduction number that is estimated from the model, and at the moment when the schools were opening, it was estimated at 1.3. And what we do is that we make a scenario that if we reduce the contacts in the rest of the society, but we keep the schools open, And we reduced the contacts in the rest of the society until the level of the full lockdown, the maximum, the most stringent lockdown that we had when the virus just was introduced, so in spring 2020. And we see that if you would reduce the contacts by 60%, then we would reduce the reproduction number to below 1. So that answers our question. So to keep schools open and still prevent a new wave, which means prevent a reproduction number being from larger than 1, we would need to introduce other measures that effectively reduce the contact rate in the rest of the society by 60%. And if you would introduce, measures as stringent as the first lockdown, we would reduce the reproduction number to well below 1 at 0.83. Now we consider another situation, and that situation is that, well, what if we would not have opened schools in August 2020? What impact would that have had? Maybe not opening physical in-person education for children could have prevented the wave. And what we find out is that the effect of the school opening, so in the reduction in school contacts, so when you reduce schools completely, it means that there are no physical, basically, contacts between children within schools. So you have 100% reduction on the X scale, and you reduce the reproduction number from the same value of 1.3 until 1.18, so almost 1.2. So actually, that tells us that even closing schools completely could not have prevented the autumn wave in the Netherlands, just because it was not enough. You start from a so high reproduction number that introducing closing schools would not have helped. So, well, I think I won't explain the graph in much detail, but basically we did the same analysis, which was ongoing during November 2020. And in November 2020, the reproduction number was already reduced to 1. So the starting value is 1. And then you can make the same type of analysis where you either reduce contacts in schools until the schools are completely closed. So this is right-hand side graph. Or you reduce other contacts in the society, but you keep the contacts in schools at the same level. And we find out, because of course you start from the value of 1, that both reducing contacts in schools and outside of schools makes a large impact on the reproduction number, and both of them, they reduce the reproduction number to roughly 0.84. So in November, actually both types of measures would be very useful to control the pandemic. And finally, we looked also at the impact of different school ages. So if you introduce measures in schools, at which school children should you target them? Should this be the youngest children, or should be the secondary schools? And we have done the analysis for 0 to 5-year-olds, 5 to 10, and 10 to 20-year-olds. It's a similar one where in November we close, let's say, education, in-person education for these types of children. And we see that in basically making this measure for the youngest children has a negligible impact, because the reproduction number, as it was at 1, and closing schools, it almost stays at the same level. And the largest impact is in the secondary school children, so which fit in the category of 10 to 20-year-olds, where you would reduce the reproduction number from 1 until almost 0.9. So a short summary for this case scenario. So all the children have the largest impact on transmission. So if you implement measures, we should target them at the older children. Closing schools after the summer break would not have prevented a second wave, and the impact of measures in general that reduce school-based contacts depends on the remaining opportunities to reduce non-school-based contacts. So in short, it's really important from where you start when you implement your measures. So I will move on to the second scenario, which concerns the vaccination against SARS-CoV-2 in Portugal. And Vaccination against SARS-CoV-2, the mass vaccination, started at the end of December 2020 in most European countries, and there was a continuous struggle how to choose measures that could keep the pandemic under control, when we can prevent the next waves from happening, but at the same time we would allow for some social and economic activity, because of course when the vaccination starts, the expectation is that we can go back to to normal life that we used to have before the pandemic. And so the questions that we had to answer for the Portuguese government was that, what is the impact of vaccination on transmission dynamics, when and which control measures had to be relaxed as the vaccination rollout was ongoing, and how can we prevent the next waves of infection. And we used a very similar transmission model. It has the same type of susceptible, latent, infectious, recovered and hospitalized type of model that I showed to you already before. But in addition, we introduced vaccination. So all individuals, so according to the guidelines in Portugal and Netherlands and Germany, so all individuals could be vaccinated, irrespectively whether they already had COVID, for example, they recovered from it. So if you had one dose, you could get vaccinated. Or if you were susceptible or unaware of any infections, you could get vaccinated, was the exception of those people who were visually very ill. So they were not advised to get vaccinated until they recover. So this is what we implement in our model, and we assume that vaccines have three main effects. So one effect is reducing susceptibility to infection, so for individuals who get vaccinated. Another one is that infectivity of individuals after vaccination, if they have a breakthrough infection, is reduced. And that was also observed in a lot of data, where the viral loads of individuals in breakthrough infections was lower than viral loads in individuals who were naive. And then the last one, and the most important one, the hospitalization probability of individuals after vaccination is drastically reduced. So these are the assumptions. And we have done this because vaccination starts at the end of 2020 only. We had to fit the model to the Portuguese data since the start of the pandemic in Portugal, from March 2020 until 15th of January 2021. And here you can see also many panels. So they also represent hospital admissions on the y-axis per day in different age categories, from the youngest until the oldest. And you see this is how the pandemic developed in Portugal. So there was a large first wave of infections. Then through summer, there was low epidemic activity. Then also in autumn 2020, a new wave started. And then there was a second lockdown introduced around November 2020. And then there was yet, because of holidays and so on, there was yet another relaxation before January 2021 due to Christmas and New Year holidays. So we reproduce this, but we also reproduce the seroprevalence. And I will show you, I will focus on the right graph where you have the total seroprevalence, so the total percentage of people basically at that time who have been infected with the virus, and it increased through time until almost 19%, so almost 20% in January 2021. And so this black dot is just, or black dots, these are the data, and the black line with a shaded area, these are the model predictions. So what we do next is that with this model we can calculate the reproduction number, how it's changed throughout time. And this was of course, because of the measures, it was going up and down. So initially it was above 2 at the start of the pandemic, then it dropped because of the measures that were introduced. So the first lockdown, through summer, it stayed barely below 1, and then it was increased again, dropped, and so on. So we can estimate the reproduction number, and we can also estimate how the contact range changed in the population through different periods. And This was, of course, because the relaxation was happening, so it was increased in summer, but then also further increased in autumn. So in this work, we tried to understand when the vaccination was introduced further, how we should relax the measures. And by relaxing measures, we mean by how much we can increase the contact rate so that we still have the control of the pandemic, so that we still have the reproduction number below 1. So we implemented a whole vaccination plan that was developed by the Portuguese government. And like in many countries, it involved different phases, and it involved different periods when different categories of individuals were vaccinated: healthcare workers, residents and staff of long-term care facilities, different risk groups with comorbidities, and then finally vaccination proceeded also by age from oldest to youngest. And so we used a very detailed data about all the Portuguese population, about all the comorbidities they have and the age distribution of these comorbidities in the population to estimate how actually the vaccination rate was projected to change through time as the vaccination rollout would be ongoing. And the vaccination rate is the number of persons vaccinated per day during the vaccination rollout in different age categories. And so you can see on the right hand side, so for example, this shows the red shows the number of people that would be vaccinated in oldest age groups, and then the number of people vaccinated in a bit younger groups is shown in orange. And actually, when we were doing this analysis, there were vaccination for less than 18-year-olds was not yet recommended, so it's not implemented. And so this allows us to project how vaccination coverage would be changing in all these different age groups, which is shown on the right-hand side. That's the total vaccination coverage with time, and it would be increasing starting from January until May. 9% of the population would be vaccinated, and then somewhere in August, it would be 38% of people, and final vaccination coverage was assumed to be 73%. There was, of course, an assumption that we had to take about what the maximum vaccination coverage would be achieved. And we use information about the surveys that were conducted in Portugal, which were saying that intent to get vaccination was very high. Vaccination hesitancy was very low, maybe unlike in some other countries. So we assumed that 90% of each age group would be vaccinated. Sometimes I'm asked, well, what actually happened? So we use these projections, but now we also have already data about the actual vaccination coverage. And in reality, the vaccination coverage actually also increased faster and to a higher level, which is shown in the left-hand graph. You see the red line is the actual data, and the black line is what we assumed in the model. And of course, there was no way to know this, but the vaccination coverage was 100% in the oldest age groups, and that was really important. In our work, we had to assume lower because actually many reviewers or a reviewer was very skeptical that we use so high vaccination coverage. He thought that that's not very realistic. Then what we do is that well, vaccination coverage is progressing, and we want to know how to relax the measures. How can we lift the measures, and how we can go back to normal, like social and economic activity. And we did various scenarios because there was no one way to do it. But the scenario which I will show to you, that's the only one, and that's about the step-wise relaxation of measures. It kind of makes sense that as vaccination is increasing, then you can allow more and more activity in the population. The question was, how exactly should this be done? So we have worked with the vaccination committee, and we proposed to relax the measures in 3 steps around 1st of April, 1st of June, and 1st of October. And in this graph, I'm showing total number of hospitalizations, hospital admissions per day in all populations. So the red dots is actually the data, and this black line is our simulation. And that's what we project, so that there would be first a very large wave, because this was the alpha variant, which was already spreading. And then it was not possible anymore to prevent actually this very large outbreak. And then we specifically chose these measures in the way that we would not see a very large increase in the hospitalizations anymore, which I call low epidemic activity. It's not zero, but it's very low and it's very manageable. So there is no high burden for the hospitals and so on. And the way how we have done this relaxation is that we proposed, as I told you, we estimate the contact rate throughout the pandemic in the population. And then we said that we can increase the contact rate in the population in a stepwise manner, so that first the measures are relaxed as to the level of summer 2020, which is this level. And then we can relax the measures until the level of the autumn 2020. And then finally, we can go to the pre-pandemic level of contacts. We can lift all measures. And the conclusion was that if the pandemic progresses in this way, that basically we can achieve the control, so we can have all our measures lifted and the reproduction number below 1 on 8th of February of 2022. So this was one of the scenarios. We also made many different scenarios. And of course, there were also unknowns at the time when we were doing it. And one of the unknowns is that we already knew that there might be different variants that could have for which the vaccine efficacy would be decreased. And we made scenarios where we assumed that there would be a different variant and for which the vaccine efficacy would be lower. And what we observed is that in the second part of 2021, if this variant arrives, there would be another outbreak if you use the same relaxation scheme, because of course, when vaccine efficacy is lower, you get more hospitalization, you get more breakthrough infections, and you get more hospitalizations. And moreover, this variant was also more transmissible. So, and also we made some analysis to understand if the people who are vaccinated don't behave as people who are vaccinated. In particular, they don't use exactly the same measures, they feel more safe. This has the same type of effect. So the question is, this was done, and this was actually used to inform policymakers. And so how did the model behave with respect to reality? Because we can now just look back. And I'm quite happy about this model, because this is just a scenario analysis. But because we included this assumption is that there might be a new variant for which there is a lower vaccine efficacy, and that variant arrived. It was a Delta variant. It arrived through the mid-2021. You see that the reality, so this is total number of hospital admissions, and actually what we modeled, while not exactly the same, was quite similar. So in that respect, that was, yeah, I think for this model, that was quite a success. So I think that at this, I would like to finish with this scenario to say that, well, what we learned, that we needed a lot of measures throughout 2021, and we needed to relax them, lift them in a stepwise manner to avoid further waves. And well, and new variants could cause new waves of infection. And that's actually what we observed. And because I think that I don't have that much time anymore, maybe I have 10 minutes, I will go a bit, maybe not through all results of the scenarios of the case, of the third case that I prepared for you. But about the main things. So of course, the dynamics during the pandemic was very complex. We have observed various waves. We have observed various variants of concern. And the question, how did this change the age-specific transmission dynamics? And we can't answer this question with normal surveillance methods that we have. So the main reason why we are not able to answer these questions with surveillance, because we don't have random community surveys. Most countries, except for UK, for example, where I think they have a survey, don't have it, even high-income countries. So we never know what is the true level of infection in the population, especially in different age groups. And knowing this level of infection is needed if you want to understand well, how which non-pharmaceutical interventions potentially need to be used. And knowing the true hospitalization burden is also needed to understand which vaccination policy we need to implement. So the question that we addressed in this last case was, well, basically this one: how did the burden of true infections and hospital admissions in children, adolescents, and adults changed over the 7 waves of 4 variants of concern: wild type, Alpha, Delta, and Omicron BA1, and during the first 2 years of the pandemic in the Netherlands. And well, we again used the transmission model. I suggest that you don't look on the left-hand side because probably that's too complex, but basically that's just an extension of the model that we had before. But we included waning of immunity after infection or vaccination. So that's the main change that we have done, because when you look at very short time scales, first wave or first couple of waves, reinfections are quite rare, and breakthrough infections, they would be rare. But as you look at the longer time scales, we know that they become more frequent. So we introduced this component. We also further stratify our infections into reported and unreported, and we estimate both. We also stratify infections into primary, so those that are experienced by individuals who are completely naive and don't have any immunity, neither after natural infection or after vaccination. And we classify infections according to reinfections and breakthrough infections. And this is done for children, adolescents, and adults, and also regionally stratified. So 2 graphs left. So, well, the question is how many infections are actually reported in the Netherlands. And here you can see on the right-hand side, these are hospitalizations in adults, adolescents, and children during 4 variants of concern. And this is the fraction of total hospitalizations. Of course, when you look at hospitalizations, the majority of hospitalizations are in adults. This is almost, well, almost 100%, not 100, but the fraction of hospitalizations in adolescents and children is quite small. However, with the variants of concern, the hospitalizations in children, the proportion of hospitalizations in children out of total hospitalizations increased. So while you don't see yellow or blue bars here, they start to become quite visible. So the burden of hospitalizations in children and adolescents increased with time through successive variants. When we look at infections, and these are split, so the purple, again, they are adults, reported and unreported, reported in a darker color and unreported in a lighter color. And adolescents is again in blue, again darker and lighter, reported and unreported, and yellow are children. So first thing that we see that a proportion of infections that were reported is approximately, well, maybe 25%. So the total is the sum of these two, and you see that reported only 25% out of the total 70, almost 90. There were also much smaller number of infections in children, so the total proportion, and again, the number of reported infections was smaller. And with time, through the successive variants, the proportion of reported infections stayed approximately the same in adults, but unreported infections decreased, while the reported infections and unreported infections in children increased. So the burden in children and adolescents increased through time. And this is one of the things that I think that was also observed, and why this happened is because actually the vaccination campaigns were lagged especially for young children, but also for adolescents. So as we were getting more transmissible variants and the variants that escape immunity, we were also having a young population which was unprotected. And last graph. So we have, we would like to understand how many of the infections or total infections were primary, and how many of these infections were reinfections or breakthrough infections through the successive variants. And we can also estimate that. So initially, of course, this is the fraction of population per age group that has a primary infection in darker color, and in lighter color, lighter purple color, is a breakthrough infection or secondary infection. So initially, in adults, of course, or in any age group, there were only primary infections, but they decreased through time. And the reinfections and breakthrough infections increased. And we see that the turning point was around the Delta variant for the adult population. So here was the shift. So the absolute minority, well, not absolute, but the minor part of infections were primary, and the rest of infections were either breakthrough infections or secondary infections or reinfections. And the pattern is different in children, where you see that even during the Omicron variant, BA1 variant, almost all infections in children were still primary infections. And in adolescents, it was split roughly 50-50. So 50% were primary and 50% were breakthrough infections or reinfections. And if you think about the hospitalizations, also the hospitalization burden decreased through time for all age groups. That's, I think, expected. That's why we perform vaccination. And during the Delta and Omicron variant, the majority of infections in adult, they were either after a breakthrough infection or after reinfection, because there were not many people who were left anymore to have a primary infection. And in children, the majority of hospitalizations obviously were just after the primary infection. And I think I'd like to leave still some time for discussion. So I will finish with this case scenario. So reported cases are the underestimate of the true infection burden. And because the reported cases, reporting strongly depends on age, it's actually very hard to estimate the true infection burden in the population. And the contribution of children and adolescents to infection burden increased with time, which is, I'm not sure whether that's known for everyone, but that's what we conclude. And also there was a shift in the pattern between primary infections and reinfections and breakthrough infections in different age groups around the Delta variant. Would you like? Okay. Okay. So I think that maybe there are 5 minutes left, about 5 minutes left. So maybe I will just finish, and yeah, thank you for listening. And if you have any questions, then you can ask them.
Thank you, Ganna. Very interesting, although I had heard some of this before, but even then, it's always good to hear it again. And then people can put questions in the chat box, or can just turn on their microphone and ask their question and put on their camera. Maybe I can start with a question. You made that comparison between, let's say, you predicted what would happen in Portugal.
Yeah.
Over, let's say, after the turn of when Delta took over from Alpha, and when the population got vaccinated. So we're looking forward to the end of 2021. And in retrospect, your model prediction appeared to be, let's say, quite predictive. Now, in the Netherlands, something different happened than in Portugal, because where Portugal was confronted at the end of 2021 with a minor wave, the Netherlands were confronted with a huge wave that actually led to a lockdown just before Omicron came.
Mm-hmm.
So what do you think from your modeling insights was let's say, the difference between the two countries that led to the different behavior of the same virus?
Yeah, I think that also happened because Portugal had a huge alpha wave, which I don't think it was as bad in the Netherlands. It was even at some point put as one of these risk countries like South Africa, so we couldn't travel there. So at some point in Europe, this pattern shifted. So Netherlands was not in line with France and not in line also with Portugal. And you could see, and that was, I think, the main reason. It was how the lockdowns were introduced. So the measures were not introduced in exactly the same way. Only the first, let's say, the first lockdown was similar in different countries, but then the rest throughout the next 2 years, it was done quite differently, and this is what led to this result. Because ultimately, all the variants they arrived to every country, right? The ones that I mentioned, they spread in every country, but that happened at slightly different time points. So I also must not say that this scenario that I said that the model performed quite well. I think that we did several scenarios, but one of those that I included, it was the one which actually the closest to the one that happened. So I don't think it's possible to predict through the whole year of what will exactly happen, because we are not doing forecasting, right? But including that scenario was important. So I don't know. I don't think that I maybe very clearly answered your question, but I think that there was a shift, a different way about how NPIs were introduced, and this has led to different dynamics. So you can't. I don't think you could use exactly model as it is and try to see what would happen in the Netherlands. You would have to take into account, all the different things, including about how also vaccination progressed. I think in the Netherlands, vaccination didn't progress as fast and as good as in Portugal, which was really compliant, surprisingly.
Yeah, they had their general telling people to get vaccinated, and that's what they did. So maybe there are more questions. Otherwise, I can talk with you more on this and then maybe put it in the email. But are there other questions from people that listened to the webinar?
Actually, this is your slide that you showed. So you said that there was a difference. So it's not exactly. So this is the Dutch. This is the Dutch pandemic with hospitalizations.
Yes, and that led to, let's say, if you go to where is so the
so
peak,
this is
peak,
yeah.
So the delta comes, and then the peak that starts at October. In October, you see the peak going up. This is exactly at the start, after the start of relaxations. And that led to a, let's say, maximum occupancy of ICU beds end of November, when new measures were introduced, and then came Omicron, and we were unsure whether that was as good as it looked like, but if there would be a scenario that Omicron would be both immune evasive and equally virulent as Delta, then
that would be.
So because of this peak just before January there, before Omicron came, we implemented a lockdown in the Netherlands in December, where other countries did not.
Yeah.
And the reason for other countries not having to do anything was because they did not have this peak in their ICU occupancy.
Yes. And you're asking why did this peak occur?
Yeah, so I think there are three hypotheses. You mentioned one is in comparison to Portugal. One is that Portugal had a bigger alpha wave, so had built up more immunity. Second hypothesis would be that there is a higher vaccination rate in Portugal than in the Netherlands. And the third was that Portugal still had measures in place in the fall of 2021 that controlled their effective R value better than the measures that were in place in the Netherlands. So that, in fact, that peak was prevented where it was not prevented in the Netherlands.
Yeah, I understand. So I didn't measure the strengths of this NPIs. Probably all three things contributed to some extent. both because either higher alpha wave or higher vaccination, everything is just that the immune landscape or whatever immunity in the population was lower in the Netherlands, or the NPIs were higher. I did not look at this in detail because I didn't compare, of course, the two countries, but now I know what question you might ask me.
So all the European countries introduced in the summer and fall of 2021 the corona pass, the pass sanitaire, or
So what Netherlands did is that at some point they allowed everyone to go to very big events. I don't think that happened in Portugal. So for example, you had this dancing with Janssen so many people had to go. That didn't happen, I think.
That was in June. That was June, July. So that lasted for 2 weeks.
Yeah.
But in the fall, and that's my personal, let's say, frustration, we introduced the Corona Pass that was not used appropriately. So the population resisted to that use, and the restaurants, or let's say the pubs and everything, they didn't control. Whereas in other countries like Germany, Belgium, and France, and I guess also Portugal, but I'm not sure, they had a very stringent control using the Corona Pass. So they really controlled it, and they checked people before they were allowed to enter meetings. Whereas in the Netherlands, this system completely failed. And that could be one of the reasons why we build up this massive number of hospitalized patients that led to the lockdown in November, December. But anyway, other questions from people in the call? Please feel free. Don't be shy. There are no stupid questions to be asked. So
no. Okay, then.
Okay, if anyone has questions, then afterwards feel free to write me an email and I can pass that on to Ganna. Maybe people just need some time to think about it.
Yeah, maybe that's a difference in the subject or in the methods. But yeah, I'm happy to help if there are any questions later.
Yeah, thank you very much for presenting. This was very interesting. Haven't had any similar topic before in the VACCELERATE webinar, but yeah, very good to hear. And thank you very much for sharing your data. And thank you, Marc, for helping with the moderation. And if anyone has any questions, feel free to write me an email. I will pass that on.
thank you very much.